Welcome to our sonography lecture on abdominal vascular pathology, part 1 of 5. This lecture will focus on aorta pathology, including aneurysms, dissection, rupture, and pseudoaneurysms. An abdominal aortic aneurysm, or AAA, occurs when the vessel wall weakens and becomes dilated. For a bulge to be considered a true aneurysm, it must include all three layers of the aorta, which are the tunica intima, media, and adventitia. By ultrasound terms, an aneurysm is identified when the diameter of the aorta exceeds 3 centimeters. There are multiple forms that an aneurysm can take. The most common is the fusiform shape, where there is an even bulging of the aorta. The fusiform shape can take years to develop. The second most common is saccular, where a pouch appears off of one side of the aorta. This type tends to be a little bit more acute in its appearance. This image shows us the difference between the saccular and fusiform shapes. On top we have the saccular version. You can think of it as a sac or a pouch off the side of the aorta. As we had mentioned, this is a little bit more of an acute appearance, so these develop very quickly. Where the fusiform shapes take a little bit longer to develop, and you can think of them as being uniform to go along with fusiform in the way that they make the aorta dilate. Abdominal aneurysms can occur for many reasons. If the reason is unknown, it's considered idiopathic. However, many AAAs have been linked to atherosclerosis. Now, atherosclerosis is a hardening of vessels, typically brought on by smoking, diabetes, hypertension, and high cholesterol. When patients have a history of any one of these conditions, it's not uncommon for them to receive what we call a screening ultrasound, where we're just looking for an aneurysm. No symptoms necessarily, we're just checking it out. Marfan syndrome is a genetic disorder in which a patient becomes very tall. They have a very long torso, long limbs, long fingers, and their quick growth and stretching of the body causes the aorta to stretch quicker than most people's. And when that stretching happens, it actually makes the aorta walls very weak, which then leads to the development of aneurysms. It's also not uncommon to perform a screening ultrasound on patients who have had family members die from an abdominal aneurysm. Oftentimes, the aneurysm is going to be a little bit more on the smaller side and really doesn't have any clinical features. However, as they increase in size, the mass can be felt pulsating in the abdomen and can be heard as a bruit or turbulent flow with a stethoscope. The patient can start to feel pain with increasing size, and if it interrupts enough blood flow to the legs, they might actually start to feel pain due to decreased blood flow. On ultrasound, we're going to be sure to look at the aorta in both the transverse and longitudinal planes. We want to evaluate the size of the aorta, making sure to include the walls in our measurements. If any of those measurements exceed 3 centimeters, it is considered positive for an aneurysm. We also want to make sure that we're looking for thrombus and calcifications around or within the lumen, and we should also evaluate the position of the aneurysm as above, below, or at the level of the renal arteries, as this will dictate the type of intervention. This image shows an abdominal aneurysm. You can see the wall here, this brighter echogenic line, and note that there's extensive thrombus within the aneurysm, causing a smaller true lumen. We always want to make sure that we are measuring wall to wall when we are measuring the aorta, so wall to wall. This one is an 8 centimeter in width, and it is 6 centimeters in AP. Both of these on their own would qualify as aneurysmal. Here's an example of a saccular aneurysm. We can see that there is this outpouching on the anterior wall. It's also a good idea to include the length of the aneurysm, so we want to measure from proximal to distal and in the AP, and we would also get a width measurement on this. This aneurysm happens to include both the distal portion of the aorta and it extends into the iliac area. Aortic dissections are when the intimal layer of the aorta separates from the rest of the wall layers. It is commonly caused by high blood pressure in conjunction with a pre-existing aneurysm, atherosclerosis, or aortic valve defects at the heart. Marfan's and Turner syndrome patients have a higher incidence of aortic dissection as well. Clinically, these patients will start with chest pain, as the dissection often starts at the root of the aorta. With each beat of the heart, the intimal flap can further dissect, causing subsequent abdominal pain. If blood flow is interrupted to the carotid arteries due to the flap, the patient may also have neurological symptoms. We're going to watch a video of a normal aorta on the left and a dissection on the right. Note how you can see the intima within the lumen. So this is our normal aorta on the left, and if you're looking at this one on the right, you can see this flap in the middle here being highlighted. Again, normal on the left and an intimal flap within the lumen of the aorta. This is kind of a string-looking appearance with that intimal flap, and is a hallmark sign of a dissection. This is a still image showing the intima within the lumen. Again, we want to make sure that we are not mistaking artifacts within the lumen as intimal tears. We should be able to see this in two planes. When you turn color on a aortic dissection, you will see that the color flow is visible on either side of the intimal flap. However, the flow is typically abnormal. If the wall becomes weak enough and a hole develops, this is considered a rupture. Small ruptures will cause blood to leak into the retroperitoneum. However, the amount of pressure within the aorta typically causes a large tear, resulting in immediate exsanguination and death. Aneurysms measuring over 7 centimeters in diameter are more likely to rupture. If a patient is stable enough to have a blood test, they would show a decrease in their hematocrit due to the internal bleeding. If enough blood is lost from the system, this will result in hypotension or decreased blood pressure. Ultrasound is not routinely used to evaluate for aortic ruptures. However, small leaks may be detected near known aneurysms. The appearance of a hematoma near an aneurysm will vary depending on the age of the blood. Recall that new blood is typically anechoic, aging blood becomes hyperechoic, and very old blood becomes complex. In this image, we can see a large hematoma that is isoechoic to the surrounding abdominal tissue. This represents the hematoma near a ruptured aneurysm. So here we can see the hematoma in transverse. This is the hematoma in longitudinal. As we look at the aorta itself, here we have our aortic aneurysm, again surrounded by that hematoma. In contrast to true aneurysms that include all three walls, there can be the existence of a pseudoaneurysm, which represents as a bulging of a vessel, but it's typically due to the rupture of the vessel that is contained by one of the walls. Pseudoaneurysms most commonly follow injury to a vessel, where the internal layers allow bleeding to occur into the external layer. Pseudoaneurysms are most commonly seen following a procedure in which a catheter is inserted into the femoral artery in the groin to allow access to the heart. When the needle is inserted into the vessel, the puncture may heal externally, but the internal layers do not heal, and blood can continue to leak in between the layers. Clinically, these patients will have had a recent procedure or injury in the area that a pulsatile mass can be felt. An ultrasound will show a blood collection next to the puncture site. With color Doppler, the flow within the blood collection will swirl around, showing to and fro color flow, and it kind of resembles the Pepsi logo, so we call it the Pepsi sign. A neck can be seen too, connecting the mass back to the artery. The neck should be measured to determine the method of closure. If small enough, the sonographer will physically use pressure of the transducer onto the neck of the pseudoaneurysm for at least 10 minutes, and if this is successful, there will no longer be flow into the pseudoaneurysm. If the neck is too wide or manual compression is unsuccessful, a thrombolytic injection can be used. However, if any of that thrombolytic medicine gets into the native artery, much more severe complications can arise. So it's not their preferred method of treatment. So here's an example of a pseudoaneurysm. We can see the to and fro flow depicted by the colors going towards and away. And so you can kind of see how this represents that Pepsi sign, or sometimes they call it the yin-yang sign. On the posterior side then, we can see the neck traveling towards the femoral artery. Here's an example of a pseudoaneurysm that has clot within it, so this has been successfully shut down. When we use that pressure, we literally are just standing, putting pressure on the patient's leg with the transducer, with our bodies, holding this neck closed as much as possible. It's actually pretty painful for the patient, and it's kind of painful for the tech. So oftentimes, if we can, we try to double up on these. So one tech can do it for 5 minutes, and another tech can do it for another 5 minutes. Once we hold that pressure for those 10 minutes or so, we double check then to see if there's continued flow into the aneurysm. Here's another example of a pseudoaneurysm. Again, you will see a pulsatile mass. It's going to have internal blood flow to and fro, showing that Pepsi sign. You should always be able to see a neck connecting back to the native vessel, in this case, the common femoral artery. And you should measure how wide this neck is. It'll give us a better idea if this patient will be successful with a manual closure. And this concludes the aorta pathology lecture. Up next, we will talk about part 2, IVC pathology.